known each other for 30 years. So this is a story that will live together. So let's open this new session. I am humbled and honored to present two different doctors, Maria Teresa Giannini and Caterina Joachim from the Policlinico University Umberto I. They will be talking about postural competence in GNAO1 patient, functional needs and suggestions. Well, you have the floor. So they are two physiotherapists. Good morning, everybody. Thank you for having us here today. Thank you to GNAO families for the reasons mentioned by Dr. Zorzi. We will be talking about postural competence, and we will give you an overview on the features of movement disorders, as Dr. Galozzi has said before. Then the postural competence and the different areas of development, its importance in the different areas of development in order to identify functional needs in GNAO1 children and give you possible proposals and answers as well. We are making reference to the review that was mentioned yesterday and today as well in the morning, Dr. Galozzi. Well, this was carried out by different Italian doctors. Well, we can see 146 cases of clinical reports and video analysis in order to better characterize MD appearance, its evolution, its onset. And in most cases, this is something that occurs in the first year of life with central hypotonia, developmental delay with main neurological alterations of the early stage. In most cases, we have trunk hypotonia with delay or absence of associated postural reactions, 72% of cases, and development delay with motor and language impairment, equals to 88.5%. So communication and movement. Well, this is something that occurs during infancy and childhood with variable onset 1 to 17 months, and we talk about mixed movement disorders with different characteristics: dystonia, chorea, choraic movements, athetosis, ballism, axial hypotonia. And this is something that we have. So this characteristic can also will make life much more difficult. So the symptoms can be combined together. So in most cases, MD progresses from limb dystonia to generalized up to tetraparesis, which is a movement disorder involving all body districts. And this is even very important. Dyskinesias and dystonias are also present at the facial level, with repetitive involuntary movements of the mouth and face and the tongue that negatively interfere with abilities in feeding and phonation, and also in expressiveness, communication, so the global overall expressiveness of the child. So there were some videos in which we saw some pre-symptomatic stages. Children may exhibit a typical pattern of grasping and manipulation of objects, as well as good visual control of ongoing activity. And this is something that occurs in the early stages. In the later stages, we have dystonic limb postures and a progressive reduction in the intentionality of upper limb movement that becomes more evident. And these also interfere with daily activities. This is very important because from a rehabilitation point of view, it is important to preserve and sustain the core of intentionality that may origin from early prior experiences. So some children have made significant experiences from this point of view. Well, we would like to focus on trunk hypotonia and the delay or absence of postural reactions and the presence of dystonic movements that involve the entire body, all body districts. From a functional point of view, we have a marked postural deficit, first of all, of GNAO1 children, and the presence of involuntary movements that pollute the voluntary act, that annoys the voluntary act, and we will be talking about that further later. Well, in terms of postural competence, if a psychomotor development is a maturation process that in the early years of life enables a child to acquire postural, motor, cognitive, and relational skills and abilities, one of the key problems in children with GNAO1 is the difficulty with postural control. We know that it is necessary for the performance of activities of daily living. So daily activities, postural control involves and allows us to control body position in space for two specific purposes. Main purposes: stability on the one hand, in terms of posture, in terms of gestures of our glance, and orientation as well, that can support the action. Postural control is necessary for the performance of intentional limb movements, and the most important function of posture is to ensure the balance during the initiation, progression of the gesture until the conclusion of the action that the children would like to do. The trunk is a key district and segment for organizing postural stability and controlling body orientation, individual movements. These are the prerequisites that support the child's acquisition, stabilization, and development of different skills in different areas of development that we will be talking about later. Well, this is an academic definition, a little bit outdated, but these definitions are very, very valid, still valid. The posture is the individual attitude taken by the individual, by the subject, defined by the relationships between the various body segments and districts in space, and thus accompanied by relative forces, muscles controlled by the CNS, and this mechanism is altered in GNAO1 children. And then there is a further aspect that we need to consider. Although we instinctively think of a static situation when we think about postural competence, there are small adjustments around the position. So there are very, very subtle movements that are started, the tiny continuous movements, and this says a lot about the complexity of this phenomenon. And the children is faced with this difficulty of organizing posture. And posture, well, is also a difficulty in terms of observation of adjustments of control. Posture is kind of a pattern of body fixation on which movement is structured. And Sherrington said that posture follows and precedes movement like a shadow. Every single movement begins with a posture and ends with a posture as well. Posture can be defined as the position of the body both as a unit, so from two different points of view, both as a unit and as the relationship between its parts, like an internal relationship. This is the first definition, how they are structured and organized in space, and as the relationship of the set of parts to the space, so like an external relationship. This space is not just the physical space, but for all individuals, also a social and relational space. When we talk about posture, we generally refer to the sitting posture because this is the one maintained for the longest time, even in adult life. And this is kind of a functional appointment in the child's development and life, since it allows and encourages different competencies and skills. First of all, we have visual skills. A child can watch when he is able to support his head on a stable trunk. In this way, he can direct his gaze and explore the space around him. And he can also explore objects and look at others, or recognize them, and begin to establish interaction and communication as well. Then we also have communication skills that are supported. We know that the child from a very early stage communicates through different multiple channels, starts with his gaze, but he modifies his postural tone. He activates expressive mimicry and gestural communication, and he slowly may use voice as well. And the sitting posture that is stable is essential to support these abilities because we have a pre-verbal level. So the fact that you can keep your trunk on your gaze on a stable trunk. You can have like cervical stability, postural ability, and this is very important, phonatory activity. And Mrs. Amantis and Dr. Amantis will talk about that. And this is also very important in terms of learning and the use of different and alternative communication systems. Well, posture also supports praxic motor skills, since the child, when he is seated, can control his sitting posture, and he can grasp something, he can take something, can manipulate, explore, he can use objects using increasingly varied and complex patterns of action. Sitting posture is essential for developing praxic motor skills. And also in the approach with the abstract, when it comes to grasping an object. And what we expect over time, the more the child extends these abilities in terms of use of objects using specific patterns, the more he plays with toys. For example, he takes pleasure in his action, he can feed his curiosity about the surrounding environment. And it is very important also to consider the transition from praxic motor activity to mental representation of actions for the cognitive development. Last but not least, we should not forget like personal adaptive skills, the child who can grasp and use everyday objects and using it on himself, complete the sense of gesture and action on himself. And this is kind of identity value, since he can do something on himself. So the sitting posture is essential for developing personal adaptive skills in terms of feeding, hygiene, self-care as well. Very important for the sphincter control as well. What are the influences and the impacts of clinical features in sitting posture in children with GNAO1 when it comes to keeping this sitting position? We may observe aposturality, so the inability to organize posture against gravity. So the difficulty in dealing with body changes in space and to move and in moving actively, since the child is not able to modulate muscular tone during this change. So we can also have different answers or responses, like axial hypotonia, for example, the so-called ragdoll, or the dystonic spasm, which is an exacerbated answer or response. We are talking also about an extensor pattern prevalence that can be activated by motor initiative and the desire or the attempt to activate himself. So attempt of activation, trying to understand what they want to do with an emotional insight or input. And he tends to actively extend the hips and slide forward with the pelvis, failing to recover the previous posture. So he loses the visual landmarks and he is not able to restore autonomously the previous posture. Then we also have the anti-gravity recruitment deficit. So when they can keep a posture, they can't keep it for a long time, this posture control. So anti-gravity posture is sustained for a very short time with subsequent lateral tilt, more or less intense, without the possibility of recovering postural position. So the child is not able to restore, once again, the previous posture. Well, then the presence of dyskinesias. So they include the presence of involuntary movements. This is a definition by Professor Choni, which represents the unpredictability and the lack of coordination. The fact that this is an irregular movement, he says that all involuntary movements can incoordinate, burden, hinder, or cheat voluntary movement, and the child with the dyskinesias is constantly in motion and is unable to maintain and to keep a stable posture. Last but not least, we can talk about dystonia, which is a movement disorder and in which we have sustained or intermittent involuntary muscle contractions that result in twisting and repetitive movements, abnormal postures, or both. Dystonic postures, as parents know it very well, are often triggered by an attempt to make a voluntary movement or to voluntarily keep a specific position. Last aspect are the perceptual disturbances, so misperception of information at different levels. First of all, we have the sense of position of the whole body and different segments with each other and in space that are perceived in a different way, so with a positional value. And we also have disperception or dispersion of some sensory stimuli like sudden, intense, unpredictable inputs that is also observed and can negatively affect posture control. So it's based on our experience. So we have one of the most important needs to help children to face movement disorganization. So we should help them build their own stability in sitting position, so trunk and head. And we have realized that the the early inclusion of postural systems allows children with a movement disorder to still be able to have development experiences and to extend their experiences that are the basis of the global development of the child's life. So we have some postural control tools as rehabilitative tools that enable to do more and other things. So this is an important message. We wanted to help children stabilizing in a specific baby's chair, and he can be supported in terms of a quantitative sense and from a qualitative sense, so he can do more as opposed to the often present exhaustibility, and he can do something different compared to what he would be able to do alone. There is no right or correct posture. But we can talk about different posture solutions that can be regarded as functional for the situation. GNAO1 children have difficulties in terms of postural adaptation when they have to change to shift their position, and they are discouraged by the postural transition attempt. This is incomplete, this is frustrating, this is strenuous, this is hard, and they can't reach the stages in which they can perform a specific action. At the same time, posture is also an expression vehicle for the child, a driver for the expression of emotional activation that causes loss of postural reference. Very often we have only one reactive modal in terms of posture in order to express different emotional situations. So their posture limits their expressiveness. At the same time, also postural solutions. So I said that there are no optimal postural solutions, but here we have a definition by Bertozzi. The choice of postural systems has to be made by evaluating what the child can do within the limits imposed by his or her pathology or disease, and what activities he or she will need to develop from that action. So the action that he is about to perform. Well, I liked this idea of a postural seat introduced at the early stage that could take the place of the hands and contact of the parent or the therapist. So the support that we give the children to support the children. So the hands and the contact of the parents' hands, they support the child in these different postural solutions. He becomes independent when it comes to watching and to looking at the interlocutor. The adult supports the child without direct contact, so there is kind of a physical space between the child and the adult, which is fundamental for the sense of identity of the child. And here, as you can see, so there are here some old pictures, and this was done on purpose. This is an important support for the child, so that the child can look into the eyes of the caregiver. So we can further support the child apart from the hands of the parent. So we can support this exchange of gazes between child and parents, and we can support the activity and the space that is created between the child and the parents and his or her parents. Here we also have two further postural solutions, and this is the static tool for the vertical movement with this message. Every time we help children to be seated and to progress in terms of trunk control, we don't limit other motor functions that are fundamental to be performed in the child, but we prepare them. So the possibility to work with a stable trunk lays the foundation for the stability of the child. We have collected and put together the most important instructions that should be considered when it comes to giving an early postural solution when a child for a child with postural disorganization. So first of all, we have to modulate in a very different way head and trunk in order to support the different levels to maintain also the horizontal character of the gaze. And another important element is the ability to maintain degrees of freedom and upper limb support for functional activity. So the expression of those skills, manipulation skills and competencies mentioned by my colleague before. Some elements that are often neglected are the ability to vary the tilting, the inclination, and to tilt to modulate the trunk statics in relation to gravity forces, because we can restore the balance of the reactivity in spite of the gravity, well, based on the reactiveness and the reactivity of the child. An important, a crucial element is the containment of the ischiatic level for the positioning of the pelvis, of the hip. And if the position is specific, is good, then we can also ensure the stability of trunk, gaze, and look as well. And then we should also place more value on the containment of lower limb joints in dystonic children or dystonia affected children, because if we contain lower limb joints at various levels, we can also relieve tension forces and lines at the level of the pelvis. So this is really limited. So time is running out, but we are almost at the end of this talk, and this is the idea. Well, the solution for this control of postural stability is something that does not limit movements, but the child can stabilize and evolve. This is the questions we ask ourselves. When are we sure that this is something good for my child? The posture is good for my child. When the child tells me, "Oh, I'm so sorry, I have no voice," if you help me to stay up, if you support me, then I can watch, touch the game, that game, and interact better with you. Thank you.
Mi scuso.
Vabbè, grazie molte anche per l'emozione finale. Perché...
Thank you so much also for this last message. We still have some time for questions. Yep.
Grazie mille per la presentazione, molto chiara secondo me. Volevo dirvi, mio figlio si mette a giocare con cose piccole, lui ha una...
I wanted to ask you, my son plays with small things. His manipulation is not perfect, but he touches those small things. He's kind of obsessed with those little things, those small objects. Is there a way to avoid it? First of all,
su questo di proporre esperienze tattili diverse in tante. Cioè...
Maybe you can increase the laying surface, and maybe you can have him manipulate small things in a greater quantity within a container so that he can experiment with the small things. He can do different things.
Buongiorno, sono una fisioterapista.
Good morning. I'm a physiotherapist. I would have many questions, but I'll prioritize 2 or 3. In Pietro's specific case, his perceptive tolerance is doing well. The use of bands and flexa, can he help to stabilize him a little bit? When you talk about containing lower limbs, considering that dystonia often come with deviation. Sometimes it's important to fix the lower limb, but the foot keeps moving, so maybe a special shoe might help him better. And third question, in my 45 minutes of therapy with Pietro, I kind of lose focus sometimes. So considering that articulation must be the focus, my time should be dedicated to trying and find an active control of the trunk. All those postural passages that we favor, or we should focus on a more correct postural design, and we work on that for what we can do in that situation. I'll stop here, otherwise I would take too much time. Those questions are very important and very hard. I would like to answer those questions, and I think you, the therapists, and the parents are the ones who can find the right answers to your questions. As for the first question, the use of postural control tools, more softer ones or more containing ones, or together. There is no right answer here. In my experience, there is only one rule that is true, which is to try.
La chiave potrebbe essere quella di differenziare.
I think the key might be to adjust the postural tools for what I am doing. If I'm working on the look, and that's very important. The more stable the child is without him having to worry too much about this. So in this case, also very containing seat, the more efficient I am for the functioning of his eyes, of his look, his gaze, and upper limbs. As for the second question, postural competences during rehabilitation must be supported and sustained, because children are small and they have a long way ahead of them. And even if they don't come to complete postural competence, having experienced it with the therapist is a perception experience that is very important for the child. So the two things go hand in hand. And of course, then you have to make choices considering the age of the child and considering how much time you have available. For instance, we know that we have a time frame for some developmental skills. So to support them from the motion point of view, to support them with other steps, it's very important. Then you can go back on it. As for the question on lower limbs, yes, a very strict containing of the lower limbs can be advised. But again, we need to understand the specific case, because the child needs to feel that the body is free to move. I don't know if I helped you with my answers. Thank you very much. Unfortunately, we have to move on so that everybody can give their presentations. I would like to